commercial banker, and then got into the dot-com boom, and a company raised about $70 million, grew it from nothing up to about 200 employees, scaled it back down, sold it off. It wasn't profitable. But then took a role with the CFO transition at a nonprofit community health center network in North Carolina. Then coming from financial services and early stage e-commerce to nonprofit community healthcare and the use of information systems, it was night and day. This is around 2004, but the writing was on the wall that sort of technology and the digitization of healthcare was coming forward, and it was like, wow, that would be something really great to be a part of. And lo and behold, Ritu and Gordon and others have founded the center here at the Smith School, sort of on the early stages of the health IT revolution. So I was very fortunate to be a part of that. And then for the last almost 8 or 9 years, have been working, or almost 10 years, working very hard to sort of help push that ball along. Because there is so much promise in the digitization of healthcare. I think most of the people here would agree. Well, what I want to do in the next 45 minutes or so, we thought it'd be important as part of today's sessions to sort of look at what is the actual evidence behind mobile and telehealth programs. I mean, what has rigorous research found? What are some of the things that are working? Where do we have opportunities? And also sort of look ahead to say what are some of the technologies that are entering this space. Some that are already here, but maybe not as widespread, that have the potential to be transformative. And then we can talk a little about sort of what's good, what may not be as good with some of these things. And given that we do have some practitioners here in the room using some of these systems, I mean, we'd be open to sort of some of their perspectives as well. So with that, let me get started. So Deputy Director Chid's here. Then we also are spinning, or what? We're in the process, we have a version 1.0 of a company, we also have a venture that we're running at the VA, which actually is mobile health based. So we use a tablet with older adults and provide mechanisms for them to track those activities which are important to diabetes self-efficacy, such as blood sugar, nutrition, exercise, medication adherence, and then take that and gamify it to make it more simple to understand. And then with certain patient groups, we'll put them in teams, and then you're sort of having a team-based approach to achieving better health outcomes in diabetes. And then we use a diabetes nurse educator as a sort of first line of interaction with those patients to sort of monitor their progress, to motivate if they see dips in certain behaviors. And then we have a number of research questions surrounding this that have to do with the personality of individuals, their behavioral and clinical activities, so we can actually get to an age of personalized mobile medicine. I mean, a lot of mobile health today is there's sort of here's your solution. Maybe it communicates with you, but it's very homogenous. But we're looking at sort of how can we make it sort of more tailored, more personalized than interactions. We think that'll be more effective.
And you said that was through the VA system?
Yeah, we're testing it right now at the VA with 23 older adults. The Baltimore VA. Our clinical PI is Dr. Nanette Steinley, who's Chief of Endocrinology there. So we work closely with her and her team, as well as the Department of Psychology here on campus.
And what's the name of the product?
It's Diasocial.
What is it?
Diasocial. Yeah. And then in my free time, I'm a PhD student at the School of Information. At the School of Information Science, looking at how we can use information systems to support different health behaviors, analytics, and other things from that. So, here we go. So, mobile health, it's going to change the world. So says everybody. Maybe. I might. So says Helms. They're right about everything. So what we're going to do now is sort of look at what is some of the current evidence base taken from primarily systematic reviews, which sort of meta-analysis of many studies over the past 20 years, with a focus on some of the most recent ones, and we'll talk about sort of what they're saying, and then also, as I mentioned, we'll look a little bit out at the technology horizon. So, I mean, when we talk about evidence, just sort of, I mean, these are facts. I mean, so from rigorous research, what does the empirical data say? More so than a white paper from one of our consulting firms. There's nothing wrong with our consulting firms. We know that this is sort of what have researchers found looking at randomized controlled trials, other sort of research that meets certain standards with evidence. And so, what we find if you sort of look across this work is, nearly every clinical study using telemedicine has been evaluated. and most of them showed benefit in some ways. And those benefits may be cost savings, better clinical outcomes, time to treat. The most frequently reported outcomes you see are clinical outcomes and patient satisfaction. And they're generally positive. But we do find that other metrics, and especially cost and return on investment, are much less reported in the literature. There's less evidence for that. And I mean, as a result of that, either they're not looking hard enough, or that's just not been designed as one of the endpoints. But I think part of the downstream effect of that is you're not seeing, as we talked about before, many payers say, oh, there is cost effective of this, so we want to do it. I mean, if you know that a clinical outcome improves, you can really say, okay, well, that has a cost impact, but it's not spelled out in the evidence that there's cost effectiveness, then sometimes it's harder to get some support from the paying organizations. And also, I mean, as we look at these, and I mean, people always say this about health IT and telemedicine, but because technology changes quickly, if you look at time to publication from when research was done, I mean, there's typically, a lag there, I mean, whether it's 12 months or 24 months. So that can be taken into consideration, but I mean, in reality, there's the difference between the technology a year ago and 3 years ago is probably not as meaningful as maybe it was 10, 15 years ago. And we're looking at telehealth and telemonitoring. It's still principally sort of interactive engagement using telephone or TV or other mechanisms. And the other thing that's sort of interesting about many of these studies too, which may be a limitation, is they're generally less than 6 months. And if you look at a chronic disease, which may be longitudinal over many years of a patient's life, when you take a 6-month snapshot, it's only telling you so much. But you can learn some things from those 6 months. And so when we look at some of the outcomes, the most frequently, quality of life, ER visits comes up a lot. Hospitalization, are they being readmitted or not? Are you from having some service in the home? Is that keeping them out of the hospital? Mortality, all-cause mortality is a frequent metric, and cost as well. These are at the highest level. And then for each specific disease, there might be disease-specific quality outcomes. I mean, these are diabetes related here, so you're looking at HbA1c or hypoglycemia or ketosis. So this study, I mean, this is from 2014, and this is home telehealth uptake and continued use among heart failure and COPD patients. It's a systematic review, so it covers almost 41 different studies. And I thought what was interesting about this particular study is what their endpoint wasn't necessarily the clinical outcome as much, but what is the actual uptake and use of the system by the patients. And so approximately a third of patients who were offered telehealth services refused, and about a fifth of the participants who did accept the intervention abandoned telehealth before the planned endpoint of the trial. So I mean, that's something to take into consideration. So even if you're offering it, there's a large percentage of people who may not be accepted, and we need to sort of think about why that is. And across these studies, these authors, I mean, they found 7 barriers and 9 facilitators. Before I go there, just to give a quick snapshot. So in this intervention that they're typically referring to for this study is, within the home, you have a scale and a blood pressure device that may be tied into a set-top box with a Bluetooth connection that's connecting via the internet to a data server. Back at the ranch, you have the hospital, a care provider, typically a cardiologist or a nurse, or John says, typically the first line of defense will be some sort of nurse or nurse educator who's monitoring that. And the patients themselves they're reading these vital signs, they may be getting messengers, they're maybe having occasional interactions with their provider. But what I want to talk about is, so these barriers and facilitators of why it was being adopted or not across these almost 40 different studies, these are the ones that were primarily identified. So one, technical problems. So just I think if it's not simple enough that you can press a button and it works, you're gonna see a drop off. Many folks, believe telehealth to be unnecessary, and it's sort of like we've been, I think, sort of these recurring themes, right? So, can you really take care of me if I'm not standing there in front of a doctor? There's still sort of a mindset against that. Yeah, and a lot of folks, and especially older folks. I mean, and not all, but in general, there's an anxiety associated with technology. And in some cases, I mean, I was kind of surprised at this next for America, but just difficulty remembering to interact with the system and when to do certain things was cited as one of the common barriers. The need for technical support comes up a lot, and on many of these sort of systems, that there's not sort of a well-defined call center or customer service infrastructure in place, and that's going to have an impact. And some folks are finding telehealth to be a repetitive process. So if I'm
Sorry, go ahead.
No, so I mean, I've seen the doctor. I've got my instructions. I know what I need. Why do I need to now get on the system? Do that. Do this. I'm doing what I've been told to do. So why that? And then, so looking at sort of facilitators of why people are using it or why they're continuing to use it. You know, this belief in sort of improved self-care or self-efficacy. And I think sort of these are important to think about sort of as you maybe sort of think about sort of marketing messages or outreach, that these might be some of the themes that are used because they've resonated with populations. So having the easy access, improving their health knowledge. I mean, ease of use. I mean, this was sort of one of the principal ones again. Easy to use. I mean, that's sort of one, and that's. I mean, we find that across the information systems domain. If it's not easy to use, I mean, no matter how great. Well, it's not that great. It's not easy to use. Having the peace of mind of that care. I mean, the convenience aspect, keeping from having to drive and or go to the hospital or health clinic. Interesting, sort of an appreciation of telehealth nurses was cited, and some will say it's sort of one of the facilitators. And we've seen some of that in our own research. I mean, that relationship that's created between the telehealth nurse, him or her, with the patient, is an important driver of continued use. So I think that sort of human capital person aspect of who you have interacting with your patients on the sort of other end is really important.
But then you assuming then in this thing, you've got the same kid, same professional on the other end all the time. Right?
It could be.
Okay.
Right. I mean, either it is or and sometimes there's sort of a dedicated sort of small team for the patient. I don't know, John, with your outreaches, is it typically the same telehealth nurse, or is there, it's going to be one of like a few?
So with the tele-ICU, we have rotating shifts for nurses, but for the programs like IBD, advanced liver disease, it's always the same administrator who books the appointment. It's the same administrator who tests with them. And typically it's one or two specialists. So it's, if you see Dr. Cross for Crohn's, you're going to see Dr. Cross for your Crohn's follow-up versus you're going to see one of 5 Crohn's specialists. So.
Yeah. And then for those folks, if you can sort of believe that telehealth is good or better than in-person care, I mean, that messaging does have an impact.
So Kenny, the barriers that were identified, as I'm looking at them, it seems that a number can be addressed via education. Technical problems, technical anxiety, need for technical support, just providing hand-holding, if you will. Was there any discussion on that as well, there are barriers, and is the barrier this high that you can step over it, or is it a brick wall that you're never going to get around?
I'm going to talk a little bit about that in my session, because that is fundamentally an adoption and use barrier. So.
Right.
And I think, so something that John pointed out earlier is, having that sort of onboarding literature for a patient that's clear, it's probably have some graphics, that makes a difference.
Yeah.
Right?
So did they figure out the barriers was the facilitator? Seems like one is a flip up the other, almost. What were the group of people that were successful and thought it was facilitating them versus the other one? Was it a demographic issue? Was it
I mean, they didn't talk as much about, they didn't go into those details. I mean, you know, 4/5 of the patients, so when they looked at, so the 4/5 of the patients who maintained use through these trials, when they talked about why that was, these are the things that they came up. And those ones that said, well, why didn't you, the third who either wouldn't participate in the trial or the 20% who dropped out, these are sort of the reasons that they were citing as why.
It'd be interesting to know about the ones, the barriers, what those individuals, whether they knew something about the telehealth before they entered into the program or entered into the patient relationship, patient-doc relationship.
Yeah, and indeed, I mean, and one of the sort of some of the moderating factors for adoption of telehealth among the patient population are sort of socioeconomic status, health literacy level.
Literacy.
And so, you know, if you're sort of if you have technology literacy as well, so, and, you know, so it kind of makes sense, right? I mean, if you're sort of less familiar with the technology or what the impacts on health may be, then you have higher anxiety and sort of less perceived benefit for the technology.
And the population again was congestive heart failure
This was a congestive heart failure and/or COPD.
and/or COPD.
Yeah.
Okay.
So there's a facilitator that I've never really seen discussed, and it kind of goes into what we were talking about from a reimbursement and maybe as the willingness of CMS and some of the other payers to start paying for this. You don't see anything about the public health benefit. So in instances where we have epidemic type situations, flu, probably the best one of the biggest known vectors is the doctor's office. You have flu patients going there around other people, or you have patients who are well who are going into an area that's just covered in germs. What about has there been any research to show that it's actually there are better outcomes for patients to stay home? I haven't seen anything on it.
Yeah, no, that's an interesting point. I don't know if there's been research. I've seen some articles on that because there's I've seen, I don't remember the exact author, but there's a correlation between your exposure to pathogens or viruses or other things at the hospital and your risk of getting infected. So I haven't seen any large-scale studies that actually sort of quantify exactly what that is, but I think that is certainly a true statement.
Because I know I've seen some interest in requiring certain medical facilities to have separate well rooms and sick rooms for waiting. It's not a regulation yet. It may be at some point, but that's got to play right into it.
Yeah.
Because you're solving that problem.
especially at the pediatrician, or most of the pediatrician offices have a wellness sick care.
Yeah, exactly.
So how many times are you perfectly well, you go to a doctor, and there's sick people all around you?
You should think of it. I mean, you almost think in the future, if you have these specific symptoms, don't come to the doctor. Don't come to the room. Turn on your app or go to your computer. And,
There have been several kiosk companies that have approached different entities like University of Miami Medical Center, where they basically, they actually have a kiosk that has all the different peripherals that can actually be sanitized. So they've actually talked to several EDs about putting that into the ED or outside of the ED, so that you go there versus going into the ED, because there's either there's not the space requirements just aren't there, so they'll put the kiosk in, they'll get a cut of the usage of the kiosk, and you can actually supply your physicians into the kiosk. It'll actually sanitize itself once the session is done, but you've got to be able to invest quite a bit of money into the technology and put that stuff in there. But,
I mean, that just reminded me, there's some new models where there are no waiting rooms. The patient goes directly into an examination room, and the clinicians go to them. So not really a house visit, definitely not telemedicine, but you can see, if the research is there kind of supporting that these waiting rooms are an unhealthy place to be, to me, that's a huge facilitator for telemedicine.
So what we really need is a randomized trial where you take a set of sick patients and then randomize them to treatment in outpatient setting versus at home and see what happens.
Yeah, I know one that they took their tablet because they used the tablet to sign in. But then they had the thing that disinfected the tablets. Because they have the tablet, and then they put it right in the, right in the.
That's right, everybody uses the same time. They don't, same pens, same tablets.
Right, yeah.
Let me just say, they've done wonderful studies in pediatrics where there's well and sick waiting room don't change, right? Because you've always got a sick, but somebody's just getting better and they're still in sick. So they've done those. It's socially a nice thing to do, right? Like having a breastfeeding room or something like that. At Right Time, where I work, we have no waiting room. If you notice, it's a big circle around the outside. People wait around the outside and go in the room. The providers go in from the inside. So that same concept, right? But I agree, not going in is better, right?
Yeah. And even, and it's sort of what you see, they tested sprinklers in the UK health system, but they had the Cisco had a health pod. And so if you were coming, you go into the pod and it had a certain set of vitals. And if you had a certain set of readings, it would say, okay, go see your doctor tomorrow. You don't need to be here at the ER. Go home. And triage that way.
But I don't think you can do that at hospitals, yeah.
Not in America.
ED cannot turn away patients.
What's the question? Are you turning away, or I mean, you're doing a diagnostic with a set of devices that are a little different than the normal standard?
That's UK, right?
Mm-hmm.
Well, practice is there.
Yeah. I don't say so. Okay. So this next study, a couple years older, but it looked at 25 RCTs for telephone support and telemonitoring for CHF. And it did found that it was effective in reducing all-cause mortality and hospitalizations for patients. But interestingly, the telemonitoring had a significant effect, whereas telephone support had a non-significant positive effect in reducing mortality. Meaning that having the call and intervention occasionally, it did not have a significant impact across these 25 studies. But both of these telemonitoring and telesupport interventions reduce hospitalization almost a fifth. So I think that's why you do see, with the increasing readmission penalties, why folks are investing more in these systems. And finding across these studies, the majority not only learned the tech easily and were satisfied with it. The next thing I want to talk about, so telehealth for caregivers. We talked a little bit about this morning, and there's been some research on this. Actually, in 2014, there was a systematic review of telehealth tools and interventions to support family caregivers. And that showed more than 95% reported significant improvements in the caregivers' outcomes. And that's usually sort of their satisfaction, their level of distress, their confidence in their ability to manage the care of their loved one. There's a lot of stress when your loved one has a severe disease. So, but this did find that the telehealth via education or having the support of monitoring or on-demand support within the home helps those caregivers and their levels of their own health levels. I mean, if you're measuring health by sort of level of distress. And interesting, and having the, and then one of the studies, so for TBI, which is one of the most common injuries that's out there, especially among kids, having caregiver telehealth support resulted in improved clinical outcomes for the TBI patients. And with, as I mentioned earlier, and as was the case with this study too, that some of the factors of whether or some of the factors regarding receptivity to the telehealth or socioeconomic status, prior experience with technology, and even ethnicity was moderating treatment efficacy, telehealth treatment efficacy. So this next group of studies was specifically on telehealth for chronic disease management, which gets a lot of bandwidth these days. So Wooten in 2012 looked at over sort of 20 years of telemedicine and chronic disease management. So it's over 141 randomized controlled trials covering over 37,000 patients. So it's a pretty large body of evidence. I mean, and then sort of the main roles within this this group of literature sort of improving the self-management of the patients and information transfer. So taking a vital and pushing it outwards. So. And then in the current, so this is a distribution of the trials. and then they're looking at asthma, COPD, diabetes, heart failure, hypertension. It's kind of hard to see the actual signals, but you'll see, I mean, you had, I mean, about the same amount of trials for the positive effect as you did with no effect. And then, you know, then many had weekly positive effects. Another way to look at that on the box plots, so in general, so across all, so on average, it's a weekly positive effect for chronic disease management, telehealth applications. I mean, yeah.
Quick clarification, so does a weekly positive mean that the significance is not 0.05 or less, or does it mean that the effect size is small?
The effect, I think it means the effect size is small. It was significant. It was significant. It was within a sort of 95% confidence interval. But that's good. I'm not exactly sure the effect size, but weekly positive, meaning that the median effect was weekly positive. And interesting, there was, and part of one of the other findings of this was interesting, is that there was no significant difference in between interventions which employed routine voice contact or which did not. So whether you had sort of the occasional live person involved or you're using sort of the automated telehealth intervention, this did not find any significant difference between this. So which is interesting because I mean you sort of think intrinsically, well, I mean the relationship, and even if you sort of look at the findings you said earlier, you know, the relationship with telehealth nurses might impact that, but across this large body of evidence, there was no significant difference. And the other interesting about this too is that there's no significant effect in trials with video conferencing. Yeah.
This was a compilation of 20 years of study of telemedicine, but telemedicine's changed significantly over the 20 years, especially a whole bunch now recently. Was there any difference in the outcomes as far, you know, from the recent advances in telemedicine versus older ones?
It's interesting that there wasn't much. They had a graph that showed sort of by year sort of, the distribution, and there really wasn't. And what I do, I have all these articles in a folder, and when we send out sort of the post sort of information for it, I'm going to include a link to this folder, so if you want to access and look at any of these reports more closely.
I mean, if they're making me drive into some place to go do this, then it's going to be weekly positive, right?
You know, I think an important conclusion though is there's not a lot of negative, right?
Right.
And you know, if you looked at any one of these diseases and you had control patients, you'd have a lot down the other way, right? Mm-hmm. Particularly the asthmatics, the heart failures, diabetics, you know, if they're not being managed. So even the fact that there was no negative is better than what you'd see if you had the control population. I don't think they're not controlled. Were they controlled with other patients?
Well, this is their effect versus the control.
They had control in everyone.
Right, so these are randomized control trials, all 100, yeah. And so, I mean, so the most favorable area of effect was heart disease across these, but on the whole, the reason was that, I mean, the evidence base for chronic disease management is still contradictory. So that points to some of what we said earlier, that, you know, there still is a need for more rigorous studies, understanding the impact, in different populations, understanding the cost benefit, because there is. I mean, there's a cost to putting these places. I mean, having the staff and the technology, and if you're only getting sort of marginal effects, then is it worth the investment? So, but not to dissuade that we should know what the research says.
I mean, one more factor to look here is the caregivers, what you talked about earlier, right? There is a lot of stress on caregivers. So even if for the patient there was no effect, but it was a good peace of mind for the caregivers, that's the future population we preventing from going into the healthcare system.
Sure. Could be. Yeah.
Another possibility, which I'm focusing and very interested in is health education. There was an event that I attended to in which they were doing in Arizona teleconferencing for education on diabetes. And another study could be done and seeing the same type of service, but one group got education, follow-ups, things of that sort, and the other doesn't, to see what type of response the use of the
Yeah, that could be one thing to look at. I mean, because I think too, I mean, if we start talking about sort of the personalization and tailoring of interventions, are you tailoring your onboarding materials, your education materials by the specific patient, or do you have, sort of your set of materials, or should there be some sort of cultural nuance besides just sort of language to different patient groups? Something to think about. All right, just moving on. So, other studies that sort of looked at sort of in the hospital-based telemedicine, and these, did find sort of they efficacy and support. So telestroke, it has reduced time to treat, and I think we know time to treat is an important factor in how well the patient ultimately fares. And this works well in sort of a hub and spoke model. Also, teleburns. I thought it was interesting that teleburns have been found from these studies. These were about 39 studies that were covered in these particular bullets. The teleburns are accurate as face-to-face assessment. And then reduction in transfers to burn units, because if you can do that assessment, maybe it's not as bad as you thought, has resulted in significant cost savings for those that are implementing teleburn. Do you do teleburn?
No, we don't.
Joe, you do telestroke.
Oh, yeah.
Leader telestroke. Yeah. Also, in teleradiology, some of the same impacts in terms of reducing sort of cost and sort of patient movements. Let's see. So, mobile health-based interventions. This is a 2013 study that looked across 75 studies that involved mobile-based devices and interventions. The two areas where there were significant effects found were in adherence to AART, so antiretroviral therapy for HIV, that was found to be effective, and for smoking cessation. And in the other areas, it was suggestive, but it was lacking high quality evidence at this point. Quinn, local University of Maryland, just randomized control trial of diabetes patients using something called WellDoc, which is a mobile app that showed a significant decrease in A1C. Also, SMS reminders have been shown to substantially increase the significance of actually we talk about adherence in terms of adhering to your clinic visit, being at the visit. It's shown to be quite significant. Let's see. Talk about that. So some of the barriers that are pointed out sort of across this literature, we've talked about these in different ways for some of the earlier practice, but I'll just go really quickly highlight again. So reimbursement is still the big barrier. Legal administrative issues, especially the liability and licensure across state lines. Provider and patient comfort levels, that's come up, that keeps coming up again and again. Lack of broadband access. It's less of a problem, I think, today than it was when many of these studies were from 5 to 10 years ago, but it's still in some areas a problem. The lack of evidence is a barrier for widespread use. To make these programs successful, we require new models of staffing, scheduling, and care coordinations from the organization, and that's a big bar. And Ritu is going to talk a little more about some of the organizational aspects of that. And then lack of integration with EHRs, and this was mentioned earlier as well. And on that point, strategically, as was mentioned, many of the big EHR vendors are buying telehealth or integrating with telehealth or partnering with telehealth companies. And I think, if you think about EHRs as the core platform in a large health or hospital, if you're not tied into that platform in some way, they might become your competitor. Overcoming barriers, again, ROI and the payers, you know the value of your solution. So the UX, user experience, is critical. Make it easy to use, push a button, it happens. Don't, you can't expect what. Because folks, from the iPhone or other supposedly sort of more useful technology, they want everything to be that easy, right? And so, and if it's not, then they're going to say the heck with it. More seamless hardware and software integration. And then we also need regulatory support. And so these sort of things are working in harmony. So you see, and this evening's dinner briefing will talk about the current regulatory landscape, which I think will be really, really insightful. Let's see, so I got about 15 more minutes, so now we'll talk about some, so that's the science, the evidence, but the technology horizon, I mean, that's sort of, I find this stuff kind of cool and interesting, but again, I mean, it's just because it's cool and interesting doesn't mean it works. And has people here heard of the hype cycle, Gartner hype cycle? Folks here, so this is the 2014 hype cycle for telemedicine. So, I mean, and they do this for all kinds of different industries that plots the specific technologies and where they are from sort of when the innovation is first triggered for use in industry. And typically what happens, you have, there's innovation, everybody believes it's going to cure cancer, solve hunger. But then they realize it doesn't, so you kind of get, kind of goes through this period of disillusionment. But then, as the technology's been around for a certain amount of time, people start realizing, how do we extract the value from it? How do we learn from it? And so they call it the slope of enlightenment, and you get to this plateau of productivity. And within the sort of telemedicine world, if you look at sort of where the productive applications are, remote ICU has been shown, as we talked about earlier, the e-visits, I mean, now, like something you can go to WellDoc, you have an e-visit. there you go. I was kind of surprised they have patient portals listed here. I personally don't think those are very, very effective the way they are. Teledermatology, which includes burns, I mean, that's doing well, telestroke. But here, when we talk about sort of where we are in the trial of disillusionment, the mobile health monitoring, I think it hasn't as excited as people have been. It's not really showing it. Let's see, sort of on the sort of where we are sort of earlier. And telepsychiatry is still kind of early stage, even though I think that's one of the most rapidly growing areas of telemedicine, telehealth, and that's showing some benefits. And medication compliance management is sort of at the peak of inflated expectations.
What's Continua 2014?
No,
that's Continua.
So Continua 2014. So there's the Continua Health Alliance,
Yeah.
which has like a certain set of standards for connected health devices.
Okay.
So I think that's there because the Continua 2014. So we have this platform which says if you operate according to this set of standards, then your blood pressure cuff can talk to your telephone, can talk to your glucose monitor.
Interfacing.
Yeah.
Okay.
But let's see, next, about 10 minutes, I'm just going to go through some of the different technologies to be aware that I think are sort of interesting. If we're sort of looking ahead, just to have these as points of reference. So the wide body area network, so a lot of sensors are using this now. So it's essentially the sensor on your body will communicate with your phone as the hub to communicate to the cloud. That might be representing the ECG, an insulin pump, breathing activity, glucose. Yes.
Just a quick comment, some surprising players in this space. So Under Armour has a big initiative in the area of wireless body area network. Of course, they want to monetize it for their fitness equipment, but I think it has broader applications as well. And Nike's just put in a lot of money into these.
Yeah, and for the NIH, and there's a group called a program called the Smart Connected Health Program. They've been investing a lot of these sort of body sensor type inventions.
Hey, can you reverse, just go back one slide?
Here?
Yeah. Did you have teleradiology?
Let's see, teleretinal video visits.
So, no.
Imaging?
Oh, it's the imaging?
Yeah.
Teleretinal.
Teleretinal, okay.
Yeah.
So my question is, and
Yeah.
Dr. Groff, I guess you qualify as the only MD in the room. A more visual representation of telemedicine, does the visual aspect lend itself to a higher degree of uptake?
You mean if you can see a patient?
Having the image.
The actual image. So whether it's an X-ray or I'm looking at teledermatology,
I mean, I think those are all helpful and they're all being applied now.
Right.
You know, it's just the regularity and by whom, right? I mean, but you have many people in each of these areas that are regularly using them, if that's what you're asking. And having the x-ray image, I mean, right now, you can have an x-ray read anytime you want, right?
Yeah.
I mean,
Well, I was struck by Dr. Sanders' comment about Watson and having many different or artificial intelligence looking at something that's just a visual representation, whether it's a cancerous mole
Yeah, well, the way that
X-ray.
Yeah, but you know, though, I mean, the way that Watson's looking at that is in the ones and zeros, the bits and bytes.
Right.
I mean,
Not the image.
Yeah, but I think the point here is that you've got the expertise of multiple radiologists or multiple physicians that have been factored into the Watson algorithm, as
Correct.
opposed to the one-on-one interaction where you've got, one radiologist or one physician who's interacting with the patient. So to some extent, there's an argument that kind of crowdsourcing of opinions gives you a better outcome than just a single physician who may be having a bad day or may not have read the latest literature.
True. Yeah.
And theoretically, it should increase the speed to an answer. It should also increase the probability of a correct answer, because you in essence have a Delphi panel
Yeah,
looking at it as opposed to just one set of eyes.
right.
And going back to the recent controversy about mammography readings. Well, one doctor looks at it, one radiologist looks at the mammography, says, yes, you do. Another says, no, you don't. Well, why can't you have 20 of them looking at the same one and come up with that opinion?
Yeah.
Well, see, in the PAC system for MRIs and stuff, they already have artificial intelligence that actually helps the radiologist, pick out anything that is wrong with it, and all they have to do is click a button and writes a report for them too. Because of reimbursement issues. Their reimbursement is so low that they cannot afford to look at an MRI image or X-ray image more than a couple of seconds. So that's what happens when you have AI, Watson and stuff come in there. Insurance companies figure out that artificial intelligence can read that, they reduce the reimbursement to almost nothing, and now you maybe take away doctor's expertise a little bit because you don't get to look at the image long enough to make a decision.
But the doctor, to Jay's point, the doctor's expertise is required to fill the algorithm.
To build them out.
To build them out, right?
Right. But then again, as you said, computers looking at zeros and ones, so they may not see something that the doctor's expertise, based on their knowledge, may say, hey, this is a area of concern, you should look at it more, if they had enough time to look at it.
The other chain of bonus, where are you doing this at? So at Hopkins, they consider telestroke looking at images. They don't do a typical telestroke model where they're seeing the patient. Ship the image, I'll look at the image, it's a bleed, it's not a bleed. For us, our physicians, different chain of thought. They need to see the image, they need to see the trend, they need to see, did they ever come back in the ED? They didn't, I need to see the facial. It's two chains of thought, and one will say radiology is enough, and one will say it's not enough. So, interesting.
Thank you.
Yeah, indeed. All right, I'm gonna go through these pretty quickly in the interest of time.
I have a question on the wireless body weighing network. Distinguish between the Fitbit and other apps that are for fitness purposes versus FDA-approved devices that are for medical readings.
Right. So the way that the FDA describes their mobile medical device regulatory guidance is if the app or mobile device is an extension of a medical device or acts as a medical device does, sort of diagnosing, treating something, then it falls within their regulatory purview. They have decided to exercise their discretion not to review things that are solely fitness and wellness, even though they might have some similarities to devices that fall under that. Like for example, like when you're wearing sort of Fitbits, you're telling you your steps, or you're monitoring your heart rate. Those are wellness. But if like you had you're measuring your heart rate, and now your app says, okay, hey, you might want to do this or take this medication, or go, even if it started saying things like go for a run or change your diet because of like the reading it's taking off your Fitbit, then you get sort of closer to that medical device thing. So, because when you start prescribing activity for a patient, that's when you move towards regulated medical devices. Makes sense.
So if it's gathering information, which is going to the web, which is getting analyzed or monitored, then is it a medical device? I mean, it could be reviewed by a physician or...
Yeah, if a physician is relying on that, is reviewing that data to make a medical decision, then yes.
But as a patient, I could routinely take what's being logged in my Fitbit website to my physician and say, okay, here are my exercise patterns for the last 1 month, right? And I could share it volitionally with my physician.
Yeah.
And the physician could very well prescribe something for me based on my fitness patterns. So the question is, does that make the Fitbit a medical device? Well, we're having an event on September 11th where some folks from the FDA are coming here to talk about social and mobile informatics and the regulatory environment. So maybe we'll set out an invite. I think you'll be interested in hearing what they have to say.
Yeah. So does anyone recognize this guy? It's the father of the quantified self. Is that Edward Deming? Yeah, it is Edward Deming. So he basically said, you can't manage what we do not measure. So the quantified self movement, which is sort of an integral piece of mobile health. Who's heard the term quantified self? Yeah. A couple more, maybe about half folks. But it's essentially, so that's sort of by taking sort of the mobile app, the big data, sensors, visualizing that data, feeding it back to someone in a way that's many times gamified for meaning it uses game mechanics, whether that's points, levels, badges, for motivation psychology. That's quantified self, and it's sort of catching on. It's sort of at the heart of many of these sort of wellness and health applications. So this is sort of, I'm not going to go through this, it's kind of a lot of stuff, but this is sort of the world of sort of wearable devices here. I mean, so it stretches from sort of first responder safety to wellness, to fitness, beauty. It said no one ever. It may have helped them lose a few pounds, but said no doctor ever. Well, that said almost 99% of doctors. No. At this point, doctors are dealing with this so much, typically with sort of like a health record and regulation and other devices. I mean, their belief that by getting somebody's step count, it's going to help them manage you better. It's not quite good. So I don't know, does anyone have the smartphone physical? So this was something that they debuted at TEDMed last year, but essentially using your smartphone, you can do a full signature body analysis with this eye health scale, BMI, oxygen saturation, blood pressure, visual acuity, optic disc visualization. You can do the eardrum, the spirometry. You do heart physiologically right on your phone with a little attachment, and the stethoscope, and you can do the carotid artery visualization as well. So that's all on your smartphone. This is possible today. They actually debuted that. I think that's just so as we think about, hey, this is future. Some of this isn't in the future. Some of this is happening now. I mean, it's not widespread that people are doing physicals on their smartphones, but depending on where you are within the next few years, I mean, okay, if you live 200 miles from somewhere, you need your physical. I mean, can I just mail you a box with this stuff and a return label? Do I really need? It's a good question.
Or giving it to a mother when her baby leaves the hospital.
Mm-hmm. Yeah, so baby scripts. My buddy has a company called Baby Scripts that they just they launched now. They're actually giving it to mothers at Sibley Hospital. Like that, it's a kit with wearable devices. You have your patient education materials that come at a regular period. And it's interesting, and so they're running the trial now to see if it actually works. But yeah,
you said Sibley?
At Sibley.
There's a company out there that provides you a take-home kit, so that when before the patient leaves the hospital, they'll get trained on how to use the tablet, how to use all the peripherals. Send them home, has educational videos. Then once they're done, if you want, they have a return shipping label, so they'll clean it. They'll basically sanitize everything and ship it back to you so you can use it again for the reduction in readmissions kind of thing. So.
Yeah. I think we've we've already talked about some of these. I mean, the only one I'll point out is, so you're starting to see devices that instead of actually even going to the Bluetooth, are actually like, this is the Telcare glucometer. So it just automatically pushes it to the cloud using the cellular signal. So you don't even have to piggyback off of anything. It's just direct push. I mean, now you have cups that are, that supposedly will you read the amount of calories and the composition of your drink. You know, if you're trying to monitor, like, because a lot of people get their calories from their beverages that they're drinking. And so if you want to monitor that, they have cups to do that. You see wearable textiles taking off recently. This is interesting. I mean, it's sort of mixing geolocation with devices. So Propeller Health, which puts a little GPS chip on your inhaler, so you can start plotting where hotspots for asthma flare-ups are in a region. And then it also gets prescriptive. So if I'm an asthmatic and I'm going near a region, I said, hey, this is where other asthmatics are actually getting flare-ups. You might want to avoid this area. That's Propeller Health. You probably recognize the iWatch. This is, it's sort of whether this is sort of snake oil yet or not. This is the Gobi. They did a Kickstarter campaign they were trying to raise $100,000. They raised over $1 million. It supposedly will measure your caloric intake via a wrist worn sensor. It uses impedance technology to do that. And it's funny, the Guardian newspaper did a sort of story to test it, and during their test, it actually works. So they're like, oh, maybe it's work. But it's still to be determined. But these are all sort of things that are coming together.
But if you do impedance, you've already had the food.
Well, right, you eat you're wearing this, so after so yeah, right.
The intake is.
I'll tell you what you eat.
Did you see the Indiegogo campaign about there's a device that you basically put up your nose for the CPAP for sleep apnea? It's basically the first wireless CPAP machine. It's unbelievable. The biggest issue is because of the wires, and people are not compliant because of all the wires and everything. They put it was probably last week I saw it start up, but it's hopefully they'll get enough money to actually come to fruition, because I know a lot of people that don't use their devices just because of all the wires and connections and cleaning and all that kind of stuff.
Yeah.
So, unbelievable stuff.
Yeah, that's really neat.
It's the mask.
Yeah, and to that point, I mean, for those that are designing devices, rolling out devices, to the extent that you can get rid of the wires or even reduce the amount of patient input necessary, that it acts sort of the degree of passiveness of the application and the data capture will be correlated with the amount of sort of use and effectiveness, most likely. So ingestibles have started to sort of take off. This is, so you swallow the pill, it takes pictures all the way down your colon tract, and it'll send the images to your phone. This Proteus Health, which puts the little chips with the medication, it'll actually read how well your body's metabolizing the medicine, because there's such a differentiation between many people and how they metabolize drugs, and so you can vary dosage more precisely, and you have sort of the phone, the application can help you with that. Which, I mean, there are certain conditions where this can be very, very critical and important, and especially if you talk about some drugs these days. When you're talking about drugs that may be $10,000, $20,000 a regimen, and if you can reduce the dosage to an appropriate level. This also plays with pharmacogenomics. You start mixing with different genomic profiles. The last thing I'll mention for this is just the Internet of Things. Everyone's probably heard that term recently. So you're starting to see sort of easy sort of connectivity to things around the home. So you might have, your refrigerator knows if you're eating or not eating, or what you're eating. If you leave your stove on, it's talking to something. Your TV that sort of knows if you're not watching or watching certain things. You may have a security camera that's also sort of picking up health signals or other things. I think this is probably. I mean, this is starting to grow. I mean, there's a lot of discussion in the discourse about Internet of Things, and GE starting to put little sensors on their stuff.
The toilet's another one, but that whole continuing care retirement community, aging in place. I mean, that's what. That's going to be
big in the aging in place market.
I heard one speaker, she was the founder of Big White Wall. She was speaking at M Health Summit,
And she was saying that, soon there could be one like where because of your smartphone and what you've been typing, then your home knows how you're feeling, and so maybe the lights will change a certain color, and help to adjust your mood, and then you can put on a sweater that actually does hug you a little tighter, and there's and things like that. But yeah, there's a lot of potential.
Yeah, no, indeed. That's right. So part of that is like effective computing, right? When we talk about effective, like the mood and stress and state. I think there's a much greater appreciation the last couple of years about how much your mood actually impacts your overall health and wellness and activity. So to the extent that these devices are helping to sort of sense and read that, I mean, I don't know how soon my lighting will change because of that, but it might.
Is that Philip?
Yes.
I do really looking for it.
Move the phone out of your room.
You think Medicare will reimburse for those clothes?
I know. Yeah, not until there's evidence. So just include. There's some evidence. There's been a lot of studies, but it's still mixed in large part. Especially on the chronic disease management front, it's still mixed. Some of the in-hospital telestroke, teleburns, it's shown effectiveness, but that the cost piece of the analysis of RCT has been limited, even though we have seen a lot of some clinical and patient satisfaction outcomes. And then, as we've looked and we've seen throughout the day in different pieces, that there's new tech, it's neat, and it may have an impact, but, how to best sort of derive that utility is to be determined. But I think we can say with some certainty that, it has to be easy to use, it has to meet good design standards, and that whole user experience needs to be, consistent with sort of best practices today. With that, I'll close this session and we can have a discussion.
Well, can I ask this a different way then?
Mm-hmm.
We're talking about health outcomes and utility and all this, but where do you see the market? Where do you see investor interest? Where do you see the ability to monetize any of this? Because the hugging sweater sounds great, but getting an investor to cut a check, that might be a different thing. So where do you see that tiny little segment?
Yes. So you've seen a lot of money going into mobile health in the last couple years. It's going into the devices. It's going into the companies that can take the data from the devices and somehow make a behavioral intervention or behavioral support for you. I think at this point now, I think that part of the market's is the investment slowing down because there's been billions invested in that over the last several years. Also, sort of like we're sort of at the point now where health analytics, the investment's starting to pull back on that. So my friends to VCs out in San Francisco, they're like, no, they put a lot of money in sort of the analytics over the last 5 years, and so there's not really new groundbreaking analytics that have been shown yet, or that are beyond sort of what's already had the millions invested in them using, and some of them are spin-offs from the NSA and others, but where's the money going ahead? I think it's the more sort of innovative, nuanced, different things. So if you look at like the drug metabolizing chip, they got about $500 million. Goldman Sachs just led their round. They get FDA approval. The sensors that are measuring something that's not already being measured. Stuff like I think somebody showed the spray-on sort of chip tattoo earlier. There's Scripps Institute and others are looking at nano devices, which I think there's going to be some money going into that soon. So nano chips that are about 90 microns but can measure certain blood chemistry and communicate externally. But in other things on sort of that nano device spectrum. I think those are where you might see some money flowing. I'm sure your apps, your sort of wearable devices, your general analytics. The investors who are sort of on the leading edge have already invested in that. But some of the newer sort of integrations between engineering, computer science, material science. That's I think where some of the dollars are going to flow.
Within all of that, do you see any really valuable two-sided networks where you start to get some amazing multiples?
Yeah.
Facebook, Google,
Not off the top of my head. One area where that I think there's a lot of promise is genetics. right? Because the next big change in the next 5 to 15 years of healthcare is the use of genetics for treatment decisions. So that's going to change sort of how drugs are prescribed, how treatments are chosen, and there's, the systems which sort of manage. There's also, there's something, so what we know about genomics is like this big because we've only been able to scan so many genomes, but in order to create that two-sided market for sort of the learning health system around that, you need to have sort of the patient side of the application, so feeding data back from patients' actual clinical activities, from EHRs and other systems that are combined with the genomic data. That's going to start creating sort of a learning about sort of what does our genetic mapping sequence means, what does that mean in terms of being very precise about the types of medicine and the types of care we're delivering? I think there's some opportunities there.
I think John had mentioned the Eric Topol book. Everybody's read that book, The Patient Will See You Now. Have you not?
I like Eric.
Eric Topol, The Patient Will See You. If you don't read the book, you can't begin to think about the answer to that question, right? And what it's going to do is you're going to integrate all of these things that you mentioned, but the patient won't be sitting in front of a doctor. Okay. Telehealth will just be one tiny little piece. Genes will be another piece. Having access to their own information will be another piece. Having access to all this information will be another piece. And the person who puts that together into a user-friendly package, will have that application. You have to read that book. I mean, it's so eye-opening and a little disturbing for physicians. They don't like it. It's sort of like, well, where am I in this? It's no different than, I don't want to say it too loud, at the university professor, right? I mean, the whole new educational system, and where does the professorial chair sit? The system of big lecture hall and somebody telling you this is what you need to know. And the kids are way past that, right? So it's the same thing. So it's a very disruptive kind of thing. The genes are pretty sure.
And so sort of just to piggyback off of that, I feel like maybe there isn't going to be a reimbursement for the sweater, but if consumers want it and you price it at $50 and you're going to buy it, I don't think reimbursement is going to be as relevant in the future. Like, I know we talked about Fitbit, and Fitbit sounds like, oh, we already understand it, but Fitbit's revenue is actually ridiculous, or net profit is ridiculous, because how much it costs to create that device is less than $2, right? And they sell them for $100, like the Fitbit One and everything. And so those are like 100x multiples of and it actually has grown really, really a lot. And so it's not the newest technology, but they actually are.
I think putting it all together.
Yeah, but ultimately.
Not any one move.
Yeah, and I think ultimately it's around consumer facing. So a lot of investment is just going directly to consumer facing products as opposed to things that would fit into the traditional clinical workflow, et cetera.
And we have to recognize that reimbursement models might be a particular way in the United States, but they're very different the rest of the world over, right?
Yeah.
So people are paying for their medical costs out of pocket.
Yeah.
So the incentives to do the right thing is really coming from the patient. So to your point, it might well be consumer demand that takes many of these technologies forward rather than healthcare providers or healthcare institutions or governments.
And I love John's story about the $49 e-visit, right? Like just skipping all the regulations in general, just doing it.
The other thing that we've seen, we've been approached by several different transportation companies, EMS, not really EMS, but the heart-to-hearts, the transportation companies that when your family member has heart failure, they come and pick them up and then they transport them to the ED. Well, they've come to us saying, we see our numbers dropping. Is there any way that we can provide services either into the home or between point A and point B? So patient is in skilled nursing facility, it's got to go to the ED. So can we, via telemedicine, equip our ambulances with solutions so that the provider in the ED can watch them go from skilled nursing facility to the ED or ED back? They're already seeing that the numbers drop, and two of the guys who actually work for Maryland Institute for EMS, who are now with private transportation companies, saying, we're equipping our ambulances with mobile gateways, and now we want to partner with you to either use your video technology or point us in the right direction, and we'll use a cloud-based technology so that the physicians can actually watch the transport, provide services, interact with the family, talk to them about any drugs, or even do stuff with trauma type victims the EMS, the county EMS, there's no money in that kind of stuff. But the private industry is where they can actually see it. They're even talking about, mobilizing stuff in cars to doing, taking it to the patient, rather than having the patient try to drive in or call 911 to get them transported. They're kind of being forward thinkers, heart to heart, transportation, TransCare. These are East Coast based companies that sometimes do state to state transfers. So.
CCRC I was working with, they're doing remote patient monitoring to bring you into their, so they're going out into the community before you have to move into their place. So to tie you in with their doctors. So they're basically, because they're a hotel, right? They gotta fill the room train. So so that's a proactive use of RPM, and you wouldn't, not talking about.
Your question on Google. Google had a thing called help outs that they tried to really promote telemedicine. It failed. They ended up shutting it down in March or April. Just there really wasn't a need. They didn't promote it. It was you had to be invited to participate in that program. It really was not anything that they were looking to expand. So.
All right, well, good. Well, nice first discussion. So thanks, everyone. So why don't we'll take a quick break, and then you'll have the distinct pleasure of welcoming Lee Drago to the stage, one of the world's foremost leaders in information system science. So let's take a break. Thanks.
One of the possibilities is to put in for a grant. I'm talking at the top of my head.
Yeah.
Putting in for a grant or something like that. I'm just saying, I'm talking too general.
Sure.
But doing the patient education.